The subcommittee will come to order. The chair will recognize himself for an opening statement. Millions of Americans suffer with severe mental illnesses such as bipolar disorder, schizophrenia, and major depression, and many of them and their families struggle to find the treatment and help they desperately need. I would like to commend my colleague from Pennsylvania, Dr. Murphy, for his year-long investigation into mental health issues and for proposing H.R. 3717, the Helping Families in Mental Health Crisis Act. Briefly, this bill would reform the Community Mental Health Services Block Grant Program by changing administration, improving data collection, and by requiring treatment standards to facilitate care. It would enhance Medicaid payments to federally qualified community behavioral health centers, FQCBHCS, make adjustments to HIPAA and FERPA, the Family Education Rights and Privacy Act, privacy regulations, and expand access to certain medical records for qualifying caregivers, create an Assistant Secretary for Mental Health who will be responsible for coordinating spending at all federal agencies on mental health, including at the Substance Abuse and Mental Health Services Administration, SAMHSA. It would make changes to key Justice Department regulations that impact at-risk or imprisoned individuals with mental illness. It would increase federal funding for certain Medicaid providers and research at the National Institutes of Health. It would institute liability protections for physician volunteers at FQCBHCS, and it would reform existing mental health programs at SAMHSA. I would like to welcome all of our witnesses here today. We look forward to hearing from your expertise and experience, and I will yield the balance of my time to the gentleman from Pennsylvania, Dr. Murphy.
I thank the chairman for convening this hearing, and I want to thank the witnesses for being here as well. In light of yesterday's tragic shooting at Fort Hood involving a soldier under treatment for a behavioral health disorder, and news this week out of Pittsburgh of a mother who said she heard voices commanding her to drown her 2 young children in a bathtub, today's hearing has a sad element of timeliness to it. But let's keep in mind, most persons with mental illness are not violent and tragically are more frequently the victims of violence. But you'll never hear the breaking news of a homeless man being robbed or beaten, or a person with mental illness losing their job. Over the last year, the Oversight and Investigations Committee I chair held a series of forums and hearings to review our nation's mental health system, and this bill, the Helping Families in Mental Health Crisis Act, as a result of those hearings. And with anything, there's misinformation about this legislation, which I'm glad you've convened this hearing so we can continue to work forward on perfecting it. 50 years ago, our nation confronted the atrocities of asylums, warehouses for those whose illnesses medical science could not yet treat. And at that time, this committee moved legislation to close those places and help individuals live in the community. Many were getting treatment, many were not. And for half a century, we have operated under the illusion that having done something, we did the right thing. We didn't. Unfortunately, that illusion has been shattered by the heartbreaking daily tragedies that prove our mental health system is broken and failing the very people who need help most. The stories are haunting and the numbers are staggering. 3.6 million people with serious mental illness don't get treatment. There's over 40,000 suicides a year, 20 soldier suicides each day, another 1.3 million attempts at suicides. There's only one child psychiatrist for every 2,000 children with a mental health disorder. It's a system where the 3 largest mental health hospitals are actually jails, and there's a shortage of 100,000 psychiatric beds nationwide for those who are in acute crisis. A rule to protect privacy that needs clarifications because it's frustrated a countless number of physicians and family members and generated over 70,000 complaints. And a mental health agency that, until recently, employed as many dentists as it did psychologists and psychiatrists. And this is what the American taxpayer buys for $125 billion. That's why we introduced this bill and engage in meaningful reform. It has several of those elements that just presented by the chairman, and empowering parents and caregivers by breaking down the barriers that prevent communication, increases access to acute care psychiatric beds, provides alternatives to inpatient care through assisted outpatient treatment, It expands access to the underserved and rural populations, creates an Assistant Secretary of Mental Health to scrutinize federal programs and promote evidence-based care, ensures mental health patients enrolled in Medicare and Medicaid have access to the full range of medications to keep them healthy and out of the hospital, advances critical research at the National Institutes of Mental Health like the Brain Research Initiative, moves promising evidence-based care like the recovery after initial schizophrenic episode, improves quality and expands access to integrated medical and mental health care at community mental health providers, extends health information technology so mental health providers can communicate and work with primary care physicians, and ensures greater accountability from the Substance Abuse and Mental Health Service Administration. For far too long, those who need help have been getting it the least, and where there is no help, there is no hope. We can, must, and will take mental illness out of the shadows of ignorance, despair, neglect, and denial, and into that bright light of hope. And it starts with the Helping Families and Mental Health Crisis Act. I look forward to hearing the comments of our witnesses today. I yield back.
Chair, thanks, gentlemen. Now recognize the ranking member of the subcommittee, Mr. Malone, 5 minutes for an opening statement.
Thank you, Chairman Pitts. This is our subcommittee's first proceeding on mental health during this Congress, and while I'm thankful to you for finally convening a panel to talk about this critically important issue, I remain conflicted and disappointed that you've decided to move straight to a legislative hearing. For over a year, we've had personal and staff discussions about the importance of the Health Subcommittee examining mental health in light of some heartbreaking events in the past couple of years. And despite this today, I and other members of the subcommittee are at a significant disadvantage because we haven't been afforded an opportunity to be at the forefront of evaluating and focusing on mental illness. As the Health Subcommittee, we should be the ones putting a full-scale effort into reviewing this and understanding it better. Mental illness is an important public health issue. According to numbers from the National Alliance on Mental Health, it's estimated that 1 in 4 adults experience a mental illness during the course of a given year. That's about 55.7 million people. Meanwhile, only about 60% of people with mental illness get treatment each year. Of these people, approximately 11.4 million adults in the U.S. live with a serious mental illness, which includes, among others, major depression, schizophrenia, and bipolar disorder. Individuals with serious mental illness can be treated effectively, but unfortunately, it has been so difficult for those who need services to break through the stigma and weighty obstacles associated with mental health, even though we know how important mental health is and how interlinked it is to all aspects of health and quality of life. What some people may not realize is that mental illness is not an isolated public health problem. Cardiovascular disease, diabetes, and obesity often coexist with mental illness, and treatment of the mental illness can reduce the effects of these disorders. So it's proven that people, families, and communities will benefit from increased access to mental health services. Despite recent vigorous debate about America's mental health policies, there's been no clear solution yet. However, we've made some significant steps over recent years. The first significant milestone was the Paul Wellstone Mental Health Parity and Addiction Equity Act, which makes sure that large employer-based insurers cannot charge more or place greater restrictions on mental health benefits than they do for medical benefits. This parity law marked a dramatic and historic step for the rights of Americans with mental health and addiction illness. When I was the chairman of the Health Subcommittee, I was proud to help play a critical role in enacting this bipartisan legislation. Of course, the parity struggle is not over. The implementation of this law is critical. Specifically, we need to ensure that there are measures in place for meaningful reporting on compliance with the law. Another significant milestone was passage of the Affordable Care Act. It includes a number of provisions aimed at improving coverage for and access to mental health services. So let me point out some of the critical details in the ACA. First, people can no longer be denied coverage because of pre-existing conditions, and this includes mental health illness. More access to the Medicaid program, which has always provided a number of mental health treatments. Mental health treatment now comes standard. Every health plan sold through an exchange has to cover a variety of medical services, which includes mental health and substance abuse treatments. And finally, the ACA extends mental health parity to all Americans, not just those who are covered by large employers, again building upon the Paul Wellstone law. Mr. Chairman, these are just the highlights of the law the Republicans aim to repeal. The ACA also includes a number of provisions that specifically list mental health and substance abuse as priority topics in programs like the National Prevention Council, Health Workforce Development Initiatives, and medical homes. And there's still a lot more to do. People will only benefit from the progress we've made if services are available and if those who need help aren't afraid to seek it. We need to build from these laws to support the continuum of mental health services at all levels of government. That's why I believe we must support efforts to increase awareness about mental health and reduce the fear, shame, and misperceptions that often prevent people from getting the help they need. And I'm committed to spreading the message that it's okay to talk about mental health because treatment is effective and people do recover. We must find out which treatments are the right treatments and how we can best identify Americans who need help, and that's why agencies such as the Substance Abuse and Mental Health Services Administration and NIH are so important. So, Mr. Chairman, there are a number of Democrats on the committee who've introduced legislation and expressed interest in working together to improve mental health in this country. I hope that if you choose to move forward on the bill under consideration today, that we can find common ground and pass bipartisan legislation. I have some serious concerns about some of the provisions of H.R. 3717, but I remain committed to working with you and my other colleagues on the committee as we make mental health a priority. Thank you, Mr. Chairman.
Chair thanks the gentleman and now recognizes the chairman of the full committee, gentleman from Michigan, Mr. Upton, for 5 minutes for an opening statement.
Well, thank you, Mr. Chairman. Mental illness affects millions of Americans and their families, yet sadly it is a subject often left unmentioned in Congress and in communities across the country. And we're working to change that. Yes, we are. Ensuring treatments and resources are available and effectively used for those suffering with mental illnesses has been a priority of this committee through the 113th Congress. Since January of last year, O&I Subcommittee Chair Tim Murphy has spearheaded a thorough review of all federal mental health programs. The subcommittee and the committee held a series of public forums, briefings, investigative hearings to discern how federal dollars devoted to research and treatment into mental illness are being prioritized and spent. And I want to commend him and those of ranking member of the Oversight Investigation Subcommittee, Diana DeGette, to ensure a bipartisan focus on these vital issues. To address the gaps discovered in the extensive and wide-ranging examination, Chairman Murphy introduced H.R. 3717 last year, the Helping Families in Mental Health Crisis Act of 2013. The bill addresses issues that are important in the diagnosing and treating individuals with serious mental illnesses. It would reorient federal funding for mental health to improve the delivery of mental health services and help improve the lives of mental health patients and their families. I'm pleased that two important provisions of that bill were included in the Doc Fix bill, H.R. 4302, that the President signed earlier this week, which was sponsored, of course, the overall bill by Chairman Pitts. The first provision will help local jurisdictions implement assisted outgoing treatment grant programs, and the second will improve access to community mental health services. Bipartisan and bicameral support for both of those provisions. I would just like to add that to those families who have been impacted by mental illness in some form, Congress is aware of that plight, and we can do better. I yield the balance of my time to the Vice Chair of the Subcommittee, Dr. Burgess.
And I thank the Chairman for yielding. I really don't have prepared comments this morning, but I did feel obligated to respond. I'm the Vice Chairman of this subcommittee as well as the Vice Chairman of the Oversight and Investigation Subcommittee. And in total, the committee through its subcommittees, this represents the 8th dedicated hearing to mental health issues between the Oversight and Investigation Subcommittee and the Subcommittee on Health and the full committee in general. So it is not from lack of attention. Chairman Murphy has made this a centerpiece of his chairmanship of the Oversight and Investigation Subcommittee, which is appropriate, but that is not a legislative committee. So today we're in the Health Subcommittee, and Chairman Pitts is encouraging us to have this legislative hearing on Congressman Murphy's efforts. And then as a Texan, I just have to say, across the country, our hearts are heavy because of what we saw down in Fort Hood last evening. When the news stories began to break, I'm sure I felt the same as everyone else across the country felt. Oh no, not again. It seems like just a few months ago that we were down for the memorial service for the 13 soldiers who were lost in November of 2009, and now we're facing another series of questions surrounding another incident yesterday. We know there will be an investigation. We know there will be answers to the questions that are forthcoming, but right now, please let's keep the soldiers at Fort Hood, their General Officer Corps, of course the people in Killeen, Texas, Harker Heights, Coppers Cove, those communities. I will tell you from first-hand experience during the memorial services 4.5 years ago, those communities came together and embraced the soldiers at Fort Hood and let them know they were not acting alone. Our military has been under great stress for the last decade. Surely this is something they didn't need, but we can all stand in their support. Thank you, Mr. Chairman. I'll yield back.
Chair, thanks, gentlemen. Now recognizes the ranking member of the full committee, Mr. Waxman, 5 minutes for an opening statement.
Thank you, Mr. Chairman. 1 in 4 adults has a diagnosable form of mental illness in any given year. More than 10 million Americans are living with serious mental illness, conditions like schizophrenia and major depression. But even as the demand for mental health services has increased, there has been an unprecedented decline in state public health, mental health spending. The federal government has stepped in to help fill the gap. The increased coverage provided by the Affordable Care Act and the mental health benefits it requires will make a substantial improvement in the lives of Americans who need these services. Already more than 7 million Americans signed up for insurance coverage through the marketplaces that includes mental health and substance abuse disorder services at parity with medical and surgical benefits. The expansion of Medicaid in many states, but not all, unfortunately, has also made a huge difference, giving millions more comparable behavioral health coverage. But there's certainly more that can be done. Today's hearing is focused on one bill, legislation introduced by Congressman Murphy, H.R. 3717, the Helping Families in Mental Health Crisis Act of 2013. There are some provisions in this bill that I strongly support. I support reauthorization of programs with strong bipartisan backing like the Garrett Lee Smith Suicide Prevention Program and the National Child Traumatic Stress Initiative. I support the provisions recognizing the important work of the National Institute of Mental Health on brain research that will help us better understand the causes of mental illness. I support the campaign to raise awareness regarding mental illness among our young people, and I support the proposal that would extend electronic health record meaningful use incentive payments to mental health providers. But I must express deep concern about other provisions in this bill. I think the bill broadly redefines the privacy rights of individuals with a diagnosed mental illness. This could discourage many people who need to come forward for care from seeking that necessary treatment if they fear that their privacy is going to not be protected. The bill cuts federal support for mental health services, administered through the Community Mental Health Services Block Grant, and conditions states' ongoing support on the adoption of new federal standards for involuntary treatment that would displace current law. So you have the federal government cutting the funds, but saying if you're going to get these funds that are left, you got to do it the way we tell you to do it. Well, this has always been a state responsibility, and this is a one-size-fits-all response. I'm not sure that's the best way for us to approach it. It proposes a dramatic reorganization of mental health authorities in the Department of Health and Human Services that would minimize the role of the main agency on mental health, the Substance Abuse Mental Health Services Administration, and would reverse efforts to better coordinate mental health and substance abuse activities. Separation of these two programs, I can't understand the reasoning behind it. And the bill undermines the important work of the protection and advocacy programs that protect the rights of people with mental illness from abuse and neglect. The bill has an important provision in it that I think we need to look very carefully at, and that's the expansion of Medicaid coverage that we're going to mandate under Medicaid, and take responsibilities that the states have been paying for and shift those costs onto the federal government. This could be billions and billions and billions of dollars at a time when we hear so often from the other side of the aisle, we can't afford the entitlements. Of course, Medicaid's an entitlement for poor people, and a lot of poor people are the people who have the greatest problem in accessing mental health services. Last year, I and other Democrats introduced mental health legislation, but key provisions from that legislation are absent from Congressman Murphy's bill. Any bill we advance should include investments in mental health first aid, mental health in schools, mental health provider workforce development. We should be looking at all ideas that have been put forward and working in a bipartisan manner on legislation that shares the goal of improving our system. I thank all the witnesses who are here today, and particularly I want to take a moment to recognize Ms. Jensen, who will share her own personal history of mental illness and road to recovery, and acknowledge Ms. Thompson, who is a constituent of mine and who will discuss her experience as the daughter of a mother with serious mental illness. And Ms. Sadanovic, I know family members close to you have had a history of mental illness, and that's true of Dr. Shern as well. It takes a great deal of courage for you to come here and speak out publicly about such difficult experiences, but it's important for this subcommittee to hear your perspectives and to share it with our other colleagues in the Congress. Thank you, Mr. Chairman.
Chair thanks the gentleman. That concludes the opening statement. All members' opening statements will be made a part of the record. I have a UC request. At this time, I'd ask unanimous consent to enter these documents for the record. One by the American Psychiatric Association, a Wall Street Journal article entitled "The Definition of Insanity, How a Federal Agency Undermines Treatment for the Mentally Ill," statement by Robert Bruce. Another Wall Street Journal article dated December 26, 2013, and an op-ed by Congressman Murphy appeared in the Philadelphia Inquirer January 26, 2014. Without objection, so ordered. We have one panel today with 5 witnesses. I will introduce them in the order that they speak. Unfortunately, our first witness, Dr. Michael Wellner, is still on a train, delayed. He'll be coming in at any minute. He's founder and chairman of the forensic panel. Ms. Sylvia Thompson, patient advocate and president of the National Alliance on Mental Illness. Dr. David Shern, interim president and CEO of Mental Health America. Ms. Nancy Jensen, person with lived experience. And Ms. Mary Stanowitz, attorney and former executive director of the Treatment Advocacy Center. Thank you all for coming. Your written testimony will be made a part of the record. You will each be given 5 minutes to summarize your written testimony. And we will begin with Ms. Thompson. Ms. Thompson, you're recognized for 5 minutes. If you'll punch the button there, pull that close to you, you may begin.
Thank you, Mr. Chairman and members of the committee, Representative Waxman. My name is Sylvia Thompson, and I'm a professional care manager as well as president of NAMI's Westside Los Angeles affiliate. But that is not why I'm here today. Today, I'm my mother's daughter. My mother was severely mentally ill from as far back as I can remember. So growing up in my family was like living in a combat zone. It never felt safe because of her drastic mood changes, paranoia, grandiose ideas, impulsivity, delusions, depression, and inappropriate anger often directed at me. As much as we loved our mother, my family was powerless to help her because she did not believe she was ill. It's called anosognosia. It affects up to 40% of those with schizophrenia and bipolar disorder, and that's a conservative estimate. Because she didn't believe she was ill, she would not stay in treatment, so she could not take care of herself, nor could she take care of me. She had suicidal ideation, delusions, hospitalizations, believed I was possessed, and would disappear for days or weeks. I'm a firm believer in self-determination, but for those who are capable. We must recognize there is a whole group of people, like my mother, who are too ill to self-direct their own care. Just take a look at the news. We can't pretend these people don't exist. These tragic stories, like this morning, they are not the face of mental illness. They're the face of mental illness that is severe mental illness that is left untreated. Our helpline is flooded with calls from family members of individuals who are imprisoned by their delusions and hallucinations. Parents beg for treatment and cannot get it. The current mental health system doesn't help them because their child is too ill to volunteer for treatment. The police can't help until after they become dangerous. It can't be a recovery model or a medical model. We must embrace both because one size does not fit all. Sometimes the recovery model works, but sometimes assisted outpatient treatment or involuntary hospitalization is initially necessary to get somebody on the recovery path. AOT would help the few who have a past history of multiple arrests, violence, or hospitalizations caused by refusing to stay in treatment. Studies show AOT reduces homelessness, incarceration, suicide, arrest, and yes, violence. It saves money, it reduces force, and it saves lives. We need more hospital beds. California has only 5 state hospitals with less than 7,000 beds. Because of that, Californians with severe mental illness are 4 times more likely to be incarcerated than hospitalized. 4 times. That would never be tolerated for cancer or Alzheimer's disease. Even at its best, California would be short over 10,000 hospital beds to help the most severely mentally ill get stabilized. We can't pretend that hospitals are not needed. We have to free family caretakers from HIPAA handcuffs so they can provide care to loved ones. How can someone ensure their loved one has a transportation to an appointment if they don't know when the appointment is? Or ensure they stay on their medications if they don't know what the medicines are? We have to prioritize the most severely ill and stop funding non-evidence-based programs and groups that impede care for the most seriously ill. Congress created SAMHSA to target mental health services to the people most in need. Only 4 in the 288 programs in SAMHSA's National Registry of Evidence-Based Practices focus on severe mental illness. That's 4 out of 288. I urge you to pass H.R. 3717. I'm not a politician. I'm not a legislator. But I am someone who has spent her life in the trenches, personally and now professionally. It's wonderful to want to improve mental health for everyone. But in the process, we absolutely cannot ignore the most severely ill. They are the most vulnerable, and they need your help. My mother struggled my whole life. Before we gained guardianship, she was living in a state of squalor, surrounded by stacks of newspaper, rotten food, human feces, dead rodents. That was how she self-directed her care. No one chooses that life. But you should also know, she spoke 7 languages fluently. She knew every opera libretto, and she was a gifted pianist. She was passionate, she was creative, and she was loving. She was someone's daughter, she was someone's sister, she was someone's wife, and she was the mother to 6 amazing children who were desperate for her to be well again. My mother's inability to acknowledge her illness was not a choice. It was a symptom that trapped her and robbed all of us of her greatness, robbed me of my mother. I'm proud to be my mother's daughter. I inherited her passion, her creativity, her outside-the-box thinking. In her memory and to prevent others from going through what she and our family did, I implore you all to please work together to pass H.R. 3717. Thank you.
Chair thanks the gentlelady, and now recognizes Dr. Shern, 5 minutes for his opening statement.
Thank you, Mr. Petz, members of the committee. I'm the interim president and CEO of Mental Health America, which is the nation's oldest mental health advocacy organization. We're 105 years old this year. We were founded by a person who had bipolar illness and have, throughout our history, stood very firmly for the full inclusion of people with mental illnesses in every aspect of American life. We have 240 affiliates around the country approximately, and are very concerned with America's mental health from a public health perspective. Prior to joining Mental Health America, I was a tenured professor and dean at the University of South Florida and a mental health researcher, a psychologist by training. And I spent my professional career really studying systems of care for people with severe mental illnesses. And of particular relevance, I think, for our discussion today was a program, an NIMH-funded program that we conducted in New York City, an experimental program using psychiatric rehabilitation technology to engage and serve persons with severe mental illnesses who were homeless, living on the streets of New York City, about 60% of whom also had a very serious addiction disorder. We were able, through the use of peer counselors who were involved in the program, and a very well understood technology, a psychiatric rehabilitation technology developed by Boston University, to engage this very difficult to treat, most in need group of individuals. We did that by emphasizing the fact that they had choices in terms of how they could organize their recovery, and empowered them to expressed those choices and empowered our team, our treatment team, to enact those choices. Through that process, we successfully housed the majority of clients. We significantly reduced their level of psychiatric symptomatology. We improved their quality of life. The important point is, I thought about these issues a lot, and it's clear to me that we have technologies that can be used to engage individuals in care. We don't always do it, but those technologies are available to us, and our challenge is to try to implement them more effectively. I'm also a family member. I think everyone here is a family member. I have a feeling if we queried the committee, we'd find out that there's not one degree of separation between many of us and a family member who has a mental health problem. My nephew had severe bipolar disorder, particularly when he was in high school. And even though I knew all the people in the United States who developed the evidence-based practices for this, because of the inadequate system of care, in this case in Pueblo, Colorado, we couldn't get Kyle what he needed. Fortunately, my family had the resources to get him into residential care, and he's doing fine now. We went through a very difficult time, a time when he was confused about what was going on with him, and so I'm very sensitive to these issues. The reason that I left academia and entered advocacy was to try to close this gap between what we know and what's routinely available to people. And there are many aspects, as many of you have commented already, many aspects of this legislation which are very important and that will seek to do that, to expand coverage. And we are, as many people have expressed, very enthusiastic and supportive of those. There are, however, some aspects about which we're very concerned. We're concerned with the emphasis on assisted outpatient treatment. It's very clear to us that the issue is having a full, engagement-oriented system of care for individuals and making those services available to those individuals. We're concerned with expansion of the Institute for Mental, the IMD exclusion, focusing only on one type of care when we realize, as Dr. Arthur Evans testified last week, that it's in fact the continuum of care which is most important. We're concerned with the what we conceive as an attack on the protection and advocacy system, and what we conceive as some very fundamental misunderstandings about the role of the Substance Abuse and Mental Health Services Administration in leading the nation's health. From our perspective, SAMHSA has led every major mental health reform during the last 50 years. Is our system what we think it should be? No. It's fragmented, it's broken, and it's not responding to people. Do we have the technology to make a difference? Yes, we do. Are we implementing that technology? No, we're not. There are several aspects of this bill which will help with that. However, it's some premises and some assumptions that are very concerning for us and that we feel ultimately will damage the system and will make it, in fact, more difficult for people to access the services that they need. We've made big progress with the Parity Act and enacting that as part of the Affordable Care Act, which was bipartisanly adopted by the Senate Finance Committee in the initial markup of the bill. It's now a chance for us to live into the possibility of that act, get people the services that they need. Thank you, Mr. Chairman.
Chair thanks the gentleman and now recognizes Ms. Jensen, 5 minutes for an opening statement.
My name is Nancy Jensen. Hi. My name is Nancy Jensen, and I'm the author of The Girl Who Cried Wolf, which tells the story of my lived experience as a person with mental illness and a survivor of the terrible place called Kaufman House in Newton, Kansas. The story of Kaufman House vividly shows why parts of this bill destroying the funding and effectiveness of PAMI and recovery programs must be removed. This bill slashes funding for PAMI's program and takes away the ability to combat evil and protects the rights of people with mental illness, including the right to choose their treatment. If this bill is law, the Kaufman House would still be terrorizing, abusing, and enslaving people with mental illness. As a former resident, I know how terrible Kaufman House was. They called what they were doing therapy. It was not therapy. It was sexual and emotional abuse. The Kaufman forced their so-called patients to be nude and do bizarre acts, sex acts, while they videotaped it. I was forced to be naked, to sleep on a filthy floor, and use a bucket for a toilet. I was degraded and told I should never get married, never have a child, never join a church, and that I would never get a job. Well, as a proudly married mother with both faith in God and a job, I proved Kaufman wrong. The PAMI program shut down this house of horrors when no one else would or could. The PAMI program freed my friends and helped get us justice. I was the first former resident to tell the state about the evil. 11 other Kansans made reports after me, but the state did absolutely nothing. How did PAMI program shut down Kaufman House when the state adult protective services could not? Well, first, the PAMI Act gives protection and advocacy agencies powers and independence to gain access in places like Kaufman House to investigate and shut them down. Without a court order, the APS was turned away. Second, PAMI program provided the P&A enough funding so that it could properly investigate the Kaufmans, and PAMI freed us and got us the right treatment and then pressed for policy changes. Third, and perhaps the most important, with PAMI, the victim is the client. The client is in charge. With the APS, they serve the interests of the provider and the state. Long story short, thanks to PAMI and its special powers and fundings, the Kaufman House was shut down, and we obtained the right type of treatment. And Arlen and Linda Kaufman was found guilty over 60 charges. The Kaufmans are in prison today, and I'm here testifying. How cool is that? This bill also takes away the PAMI program's ability to educate policymakers. The PAMI program worked with me as a survivor to change policy so future Kaufman houses could never happen again. Licenses are now required, guardianship laws are fixed, and now there's an abuse and neglect unit was started. PAMI does not just help victims of abuse. This bill makes it harder for people with mental illness to find housing, employment, and education. It prevents individuals with mental illness from receiving the treatment they choose. Another important lesson from Kaufman House is the need of recovery programs, like Alternatives Conference. You must have recovery programs to have recovery. Finally, I believe this bill is misnamed. The Helping Families in Mental Health Crisis Act. Well, I want to respectfully point out to the subcommittee that the focus needs to be on helping the individual with mental illness and crisis and through recovery. Yeah, families are really important support, but the focus needs to be on the person and their recovery. Thank you.
Chair thanks the gentlelady and now recognizes Ms. Stanowitz, 5 minutes for an opening statement.
Thank you, Mr. Chairman, members of the subcommittee. I have been involved in advocacy for people with severe mental illnesses and their families for many years. And I really had no hope that some of the things that have created barriers to treatment would be addressed until Congressman Murphy introduced the Helping Families with Mental Illness Crisis Act, or Mental Health Crisis Act, excuse me. I, too, want to talk about the Protection and Advocacy Program. While I think the original intent of the program and the original practice of the program was very important, it has lost its way. And I'll share a personal experience that is very difficult to talk about. My sister has schizophrenia. She's been ill since she was 18 years old. She has spent most of her adult life in state psychiatric hospitals. For the most part, she has received good medical care, and they have protected. My sister was very vulnerable. But in 1998, the state hospital that she was in closed. She was moved to a hospital that had less than 500 patients. But because of the loss of beds due to the hospital closure, The patient population grew from 500 to 750 patients by 2007. I knew what was happening at the hospital to some extent, and I was able to get her moved to a facility that was safe. But a few years later, I was able to get her medical records, and I found out what was really happening and just how bad things were. And I'm still haunted to this day by what happened to patients that didn't have a family to protect them. And the Protection and Advocacy organization was nowhere to be found. The problem is that the bill that created Protection and Advocacy was enacted in 1986. The first finding in that bill is that patients or persons with mental illness are vulnerable to abuse and serious injury. And so it created a federally funded organization, independent of states, to monitor care of patients in hospitals and facilities. Now, at that time, there were 250,000 people in state psychiatric hospitals. Now there are fewer than 35,000. And the protection and advocacy organizations have changed course as a result, and not necessarily in a good way. I'll give you an example from Massachusetts, which is the state where I live. That organization reported spending more than $250,000 on lobbying, federal funding on lobbying against state measures. And more than $100,000 actually went to professional lobbyists. But it isn't just lobbying that's the problem. In Massachusetts, that organization got government funding to conduct a study of community services, which to me is very important because I have a brother with schizophrenia who lives in a group home, and I'm his guardian. And I work very closely with staff and the management of that group home to make sure he is safe in the community. But I was appalled when I read the report, and one of the findings was that guardians should not be involved in protective measures that should be used for individuals living in the community. And finding that GPS devices that are used for people who have a history of wandering and getting injured are a violation of individual rights. It's just a perversion. If you look and compare with the Alzheimer's Association's view on that, they find it an appropriate use of electronic devices to have a comprehensive safety program for people who need it and may be unsafe in the community. So I want to say that Congressman Murphy's bill really will do what it's named, and that is it will help families who are in mental illness crisis. Thank you.
Chair thanks the gentlelady and notes that Dr. Wellner still has not been able to get here. If he comes in during the panel, we'll permit him to give his testimony at that time. But I will begin the questioning now and recognize myself 5 minutes for that purpose. Ms. Thompson, in your experience, has the HIPAA privacy rule been misapplied to the effect that it serves as a barrier for helping the very people responsible for managing or providing care in the community?
Absolutely.
Could you expound on that?
What my experience was with HIPAA was that my family was consistently kept separate from my mother's medical needs, healthcare needs, psychiatric needs. We were unable to talk to physicians until we got guardianship at the end, which we weren't able to get guardianship until the last 9 months of her life because of the difficulty in gaining access to physicians telling us what was going on. We, as a professional advocate, I learned how to communicate with doctors. Most family members don't have that knowledge. I was fortunate enough to have gone through the training and professional experience to be able to tell a doctor he doesn't have to say anything to me, but he has to listen to me. Most family members don't know that that's their right to say something. And so there's a lack of education on both sides. And the continued hiding behind HIPAA has got to stop.
Ms. Stanowitz, in your opinion, how has the legacy of deinstitutionalization of the mentally ill worked out over the past half-century?
Well, this is one of my most passionate issues because I've seen the effects of closure of state psychiatric hospitals. And that's why I think the IMD exclusion is so important. I view it as a discriminatory provision because it is the only population that is precluded from Medicaid coverage in hospitals. Perfect example is when the hospital was closed where my sister was, and she was moved to the other hospital. And there were not enough hospital beds left, which created this overcrowding, which just prevented people from getting treatment. Now, on the other hand, I do want to recognize with Congressman Pallone, Congressman Lance, that New Jersey has what is a gem in terms of psychiatric hospital treatment, and that's the Greystone Psychiatric Hospital, and that's where my sister is now, and she's receiving just superior treatment. So it can be done correctly, but if you continue to close hospitals, there won't be enough beds, and people will end up where they are now, in jails and prisons. And I just finished a survey of all the jails and prisons across the country, and I can tell you they are the new psychiatric hospitals.
Ms. Thompson, back to you. If you could choose one thing that the government could have done to help your family, what would it be?
Just one?
Well, you can name more than one.
It would be that my mother was protected from herself. I come at this from so many different angles. I understand patients' rights. I wholeheartedly believe in them. I help fight for them. But when someone lacks the capacity, there's no shame in lacking capacity. When someone lacks the capacity, we need to take care of them. And that did not happen with my mother. She fell through the cracks over and over and over again. And if there had been more support for her, there would have been ongoing treatment for her. When my mother when my mother went through treatment, she'd come back and everything would go back the way it was because there was no follow-up. She came home. We didn't have the ability to do what we do. I see it with families now. A family member, a son or daughter is hospitalized for a 72-hour hold and gets discharged home, and the parents don't know how to create the right environment to keep that person on the road to recovery. They don't have the skills. There needs to be ongoing support. There needs to be the more IMD beds. There needs to be this ongoing system of support for family members and for the person with the diagnosis.
My time has expired. The Chair recognizes the ranking member, Mr. Pallone, 5 minutes for questions.
Thank you, Mr. Chairman. I'm trying to get two topics in with Dr. Shern, so if I cut you off a little bit, it's because I'm trying to get to the second set of questions. The first relate to ACA and compliance with parity laws. As I said, Mr. Chairman, I'm pleased we're having this hearing, but I'm troubled by a number of provisions in this bill. But it is a wide-ranging effort to address some important issues. I wanted to discuss, again, the Affordable Care Act, the Mental Health Parity and Addiction Equity Act. Mental Health Parity Act enshrine in law the principle that mental health care is just as important as physical health care. And then the Affordable Care Act not only extended this principle to the individual health insurance market, it also required that all expanded Medicaid programs, as well as individual and small group health insurance plans, cover mental health and substance abuse services as part of the essential benefits package. I hope my Republican colleagues understand that they are voting to repeal these advancements for mental health when they support the Ryan budget or vote to repeal the ACA. So questions. Dr. Shern, what is your view of the importance of health insurance coverage and mental health parity in expanding access to treatment and improving health?
It's absolutely critically important. You know, because of the development of the mental health treatment system in the United States, we have systematically discriminated against individuals with mental illnesses. That was largely repaired with the parity bill, and then further extended into markets that the parity bill didn't apply to by its unanimous incorporation into the Affordable Care Act. Getting to people sooner with effective care is critically important in terms of trying to stem these problems. Insurance access is a major impediment for individuals with mental health and addiction conditions, so it's critically important.
All right, and then secondly, these laws were clearly major steps forward, but effective implementation and enforcement are essential. What more can Congress do to ensure health insurers are fully complying with the letter and the spirit of both the ACA and the parity law?
Well, I think that the House bill that's under consideration provides an excellent opportunity to provide resources to the Department of Labor and to the Department of Health and Human Services to assess the degree to which the parity bill is being effectively implemented across the United States, and to provide ongoing guidance to insurers and payers and primary consumers about what they should expect to be their rights under this bill, and the appropriate boundaries with regard to insurance coverage. So it's a complex bill. Equity in coverage is not something that's easily determinable. It has a large state influence, so I think it's very important that we systematically monitor it, and that would be, I think, a very helpful addition to this legislation.
All right, thank you. Now I want to get to this Wall Street Journal editorial, which I think the chairman introduced into the record. They ran an editorial that sharply criticized SAMHSA's efforts to provide services that help individuals prevent, treat, and recover from mental health disorders, and they called SAMHSA the vanguard of the legal advocacy and anti-psychiatry movement, accused the agency of wasting taxpayer dollars on programs that do not help those with most serious mental illnesses. Obviously, these are very serious allegations. How would you respond to this editorial's characterization of SAMHSA?
It's, from my perspective, almost entirely inaccurate. If you look at the major, we talk about the deinstitutionalization and the problems with deinstitutionalization, and that surely was a policy that was well intended but very poorly implemented. If you look at every major reform since deinstitutionalization, in terms of improving services for people with mental illnesses, many of the things we talked about today, SAMHSA has been the champion of their reform. They started the Community Support Program, which was the first effort to try to build an adequate community treatment system for people with severe mental illnesses. They started the Child and Adolescent Support Program. With Congress's support, they implemented the Assistance of Care Act. They've implemented acts around treatment of people with dual disorders. We could go on and on and on. I think one of the things that just is unfair is this characterization of SAMHSA as though it's some sort of an entity that's anti-psychiatry, anti-treatment, anti-medication. That's just not true.
All right, let me get to the editorial also claims that very few of SAMHSA's evidence-based programs focus on individuals with serious mental illnesses. Can you comment on SAMHSA's work in that area?
It's the, our estimate is that over 80% of the, number one, remember that SAMHSA is an agency that addresses both mental health and substance use issues. If you look at the mental health proportion, our estimate is about 80% to 85% of their resources are spent on issues related to and persons who have severe mental illnesses. So again, I just feel this is a gross mischaracterization of the SAMHSA program.
Thank you.
Chair, thanks, gentlemen. Now recognize the Vice Chairman of the full committee, Ms. Blackburn, for 5 minutes for questions.
Thank you, Mr. Chairman. I thank each of you who are witnesses for being here and for adding to the work that we have done. I do want to thank Dr. Murphy for the work he has done with our committee. I think that because of the work he's done and concerns that we are hearing from our constituents, especially now that we're highlighting this issue, we have learned about the size and the scope of untreated mental illness and exactly where it affects families and individuals. We've also, and Ms. Thompson, this speaks to some of yours, we've talked about the privacy laws and the impact that has on public safety, and also looked at federal resources and how those are utilized. And you are certainly adding to that discussion today, and we appreciate it. And we're pleased with the components that the new legislation would put in place. Some redirection, some refocusing, and we think that those are good and they're appropriate. I do have a couple of questions that I wanted to ask, and I will be brief on these. Ms. Thompson, I did want to come to you first. I want to thank you for sharing your story. And as we looked at HIPAA and FERPA and the privacy issues, what I would like to hear from you, as we look at reforms, through what you've experienced firsthand and what you've learned through your caregiving and your advocacy, give me maybe the top 3 or 4 things that you would say this is what you need to change as you look at HIPAA and FERPA reforms. Do you have that laundry list? Could you give that to us?
I don't know if I have a laundry list, but I can tell you that I think what's important is that when somebody is, if somebody, I work with a developmentally disabled population as well. Yes. It's automatic. They have a condition before the age of 18. So there's no HIPAA violation. The parents are clearly the guardian. They become the guardian at, you know, they go through the legal, what's legally necessary.
They've been through the qualification.
Correct. What happens with mental illness is that oftentimes that doesn't present until after the child is no longer a child. So at that point, you're trying to shut the barn door after the horse has left, if you'll forgive the analogy. Yes. There need to be some qualifications in place with HIPAA that make it clear when somebody is not able to make decisions, when there's a question as to their safety or the safety of others that relinquishes professionals, that doesn't allow them to keep their hands tied.
Okay, so almost like a revisit of a power of attorney.
Yes. Right now you can try to get the individual to sign off, but if somebody doesn't think they're ill, they're not going to sign off permission. That doesn't mean they're not ill and not in need of help.
So you would encourage us to have some type allowance or avenue that end of oversight could be, you could negotiate.
Like a waiver. And maybe that, I don't know, as I said before, I'm not a legislator, I don't know, maybe having, if the physician deems it necessary, or maybe there's getting 2 physicians to deem it necessary, that HIPAA can be broken in this instance. It can't just be because somebody is going to commit a crime or they're going to kill themselves. They need to get help before that.
Okay. Ms. Stanowitz, I can tell you want to weigh in on this. I see you nodding your head.
I have to agree completely. Okay. I actually would say the same thing. I was unable to get information about treatment for my brother and sister until I got guardianship. And I paid $5,000 to get guardianship for my sister, who was in agreement. She did not object to it. But I had that in order to get information. But even with that, when I know, for example, my brother is in a hospital, a particular hospital, I've been told he was transferred there. And I call, and they say, we can't tell you if he's here. And then I will fax my guardianship papers, and they'll still say, HIPAA prevents us from talking with you. And then I learned later that they have changed his medication in a way that I already know is not helpful, and there's nothing I can do about it. It's too late. People don't understand HIPAA, and I often tell families, if you're told that they cannot tell you anything about your family member, you're still free to tell them what they need to know about your family member. It's a terrible obstacle for families to help, and I totally support the revisions to that portion of the bill.
Thank you. Yield back.
Chair thanks the gentlelady. Now recognizes the ranking member of the full committee, Mr. Waxman. 5 minutes for questions.
Thank you, Mr. Chairman. I want to apologize to the panel because there's another subcommittee meeting at the same time, and I've been required to go back and forth. But I do want to say that, Ms. Jensen, I want to start by thanking you for being here today and telling us your story. It's a deeply personal one. And I was struck by the utter failure and inability of authorities in your state to bring an end to the terrible abuses of people with mental illness, including yourself at the Kaufman House. That is until the P&A became involved. Can you elaborate on whether or not Kansas was an outlier and not adequately addressing complaints about the Kaufman House prior to the P&A's involvement? You think it's unique?
All I can say is that there was 12 complaints to the Adult Protective Services, and he even sued the Adult Protective Services, and so they quit coming to the door. And so I believe that, I know for a fact, if it wasn't for Pammy, Kaufman House would still be going on.
We've heard from witnesses today that P&A's lobby, and in fact, in the testimony, you worked with the P&A to change laws that would prevent future Kaufman houses through licensure requirements, guardianship laws, and the establishment of an abuse and neglect unit. Can you clarify whether the federal funding was used for these activities and any other lobbying activities? Do you know?
No, there was no federal funding. I and my friend, we just never wanted it to happen again. So we were a volunteer. We did it ourselves, and it was just an educating us on issue, but there was no financial spending of federal funds to get these laws passed.
Proponents of the PAMI proposals in H.R. 3717 claim these provisions will return the program to its roots, but it seems to me that an 85% reduction in federal funding would do much more than that. How would a funding reduction of this magnitude impact the ability of the P&A in Kansas and P&As around the country to protect the rights of people with mental illness?
I am so scared that if you take Pammy away, and that's what would happen, that there wouldn't be any protection for us if we were being abused, neglected, or exploited. There wouldn't be anyone coming in and taking us out of that situation in order to talk to us and investigate the situation. And I just ask not to do that.
Not to do that. Well, your testimony is very persuasive and I think quite valuable to us to hear that point of view. I want to ask Ms. Thompson and Dr. Shern, I'm pleased that our colleagues and I have some points of bipartisan agreement on issues before us. We all believe that mental health care is an essential part of our health care system. We agree that we need to work to end the stigma that surrounds seeking treatment, and we agree that we need to invest in community-based approaches for care so that individuals who need help are able to get it. And I think everybody here on the panel would agree with these goals as well. But I also believe that witnesses invited by both Republicans and Democrats today agree that expanding access to health insurance and improving health coverage of mental health services are critical. Ms. Thompson, as a general matter, do you think individuals who have health insurance have a better chance of getting into treatment for their mental health conditions?
I'm sorry, can you
If you have
clarify the
health
question?
insurance, don't you have a
Oh,
better
absolutely.
chance? Yeah. And do you think including mental health coverage as an essential health benefit and requiring it be covered at parity with physical health were important steps forward?
Yes.
Dr. Shern, do you agree with that?
Absolutely. Absolutely.
I think, Mr. Chairman, we could learn a lot from these witnesses. There's a lot more to the ACA than we can fit into 30-second attack ads, but it advances a number of essential priorities that both sides agree on. And I hope we can agree that it's here to stay, that we should build off of these things that we agree on in the law rather than constantly focus on repealing or undermining it. I see my time is over, and I'll yield back the balance.
Chair, thanks, gentlemen. Now recognize the Vice Chairman of the subcommittee, Dr. Burgess. 5 minutes for questions.
Mr. Chairman,
I'm sorry.
if I may.
Go ahead. I didn't see
I did want to just elaborate on one point that was made, and that is about the money that is used, the federal funding to lobby. And that's documented. You can find that in IRS reports and state lobbying reports that, in fact, the federal funding is being used to lobby it. And professionally, I have seen it done. I have been with up against employees, lawyers of protection and advocacy organizations lobbying in state capitals against state legislation. So it does happen, and it is not the original mission, and it takes away from what they're supposed to be doing.
And it's in violation of the rules that say that they cannot use that money for lobbying. So we got to get on top of that.
And so I think that it's in order for them to be able to do what they're supposed to do, which is monitor, like they did when you were being abused, I think that would be a significant improvement. So thank you.
Chair, thanks. The gentlelady now recognize Dr. Burgess. 5 minutes for questions.
And please let the record reflect the generosity and time that I gave to the ranking member of the subcommittee. We don't often have areas of commonality, but I thought that was important to have that follow-up. Well, the majority of my questions are for Dr. Wellner. One of my big objections to these types of hearings is we never have an MD on the panel. Thank you for calling an MD. Unfortunately, he hasn't, because of travel issues, he's not been able to join us, so I'm going to submit my questions to Dr. Wellner for the record. But Dr. Schern, your discussion with Ranking Member Pallone brought some things to mind, and really this is more of just reminding people of the process, yes, the budget process, legislative process, the process in the agencies. Go back just for a little bit to the Mental Health Parity Act, and I don't know how many people now remember Mental Health Parity Act, introduced by one of our colleagues, Patrick Kennedy. Indeed, we had hearings in this subcommittee many years ago. The Mental Health Parity Act was used as the vehicle to pass the Troubled Asset Relief Program to absolutely unrelated proposals. Now, I just want to be clear, I actually opposed both of them, so that no vote actually did double service that day. But to think that we passed something of the magnitude of the mental health parity and its effect upon caregivers and third-party payers as a vehicle to bail out banks, I'm still bothered by that nexus, but nevertheless, that is what happened. The Mental Health Parity Act had not actually been scored, to the best of my recollection, by the Congressional Budget Office. A similar bill over the Senate had. I think it estimated some significant budgetary outlays over a 10-year period, but be that as it may. Now, the Affordable Care Act actually passed sometime after that, about a year and a half after that, signed by the President in March of 2010. The part of the Affordable Care Act dealing with essential health benefits was actually subject to a rule. The rule was supposed to be published and concluded in August of 2012. I don't want to seem cynical here, but the actual rule was delayed until a couple of days after Election Day in 2012. I don't know why the administration would see an advantage to doing that, but apparently there was. And if you'll recall, much of the difficulty that subsequently happened to the Affordable Care Act was because of that delay. The governors were required to disclose whether or not they would participate in state exchanges on November 18th. The Essential Health Benefit Rule was published on November 8th. So that gave them precious little time to actually evaluate, is this a good idea or bad idea for my state? To be fair, they were given 2 extensions, but finally by January of 2013, the governors had to declare. 26 states said, no, thank you, we're not doing an exchange. 4 states said, well, maybe we'll do one, but we'll let the federal government set it up. So the fact that so many states were not doing their own exchanges, and that task then fell to the federal government, and clearly the Center for Consumer Information Insurance Oversight was not up to the task of standing up a massive new information technology project in the 8 months that they had available. I think we all know the story on that. But here's the issue. Okay, Mr. Pallone is right. The Mental Health Parity Act and the ACA, the nexus of those two things does affect stuff. None of that, because the way the Congressional Budget Office works, we only get information about bills before we pass them. Sometimes we don't even get that. But we only get that budgetary information as the legislation is coming through the process. We don't get a rescore by the Congressional Budget Office when the rulemaking happens. So if you take the combination of the Affordable Care Act and the Essential Health Benefits, when the Mental Health Parity Act was passed, it said, we're not requiring you, Mr. Private Insurance Company or Mrs. Private Insurance Company, to offer mental health benefits, but if you do, they need to be on a par with other medical services that you offer. That's true. Some concern that there were companies that were going to drop out of the mental health business. A year later, we have the Affordable Care Act passed, and it says this is part of your essential benefit package. I'm from Texas. I'll never attribute to coincidence that can be adequately explained by conspiracy. But the Mental Health Parity Act was passed in 2008, and the rule was not published until last November. And I can't help but wonder if the reason the rule was not made public until all of the Affordable Care Act stuff was in place was because this is going to blow the cost way beyond anything that anyone projected for the Mental Health Parity Act or for the ACA. I don't know the answer to that question. I think it's one that we're going to have to ask our congressional budget writers to help us with, but it just underscores the difficulty of making budgetary decisions on these types of issues. There are always things in the future that will affect them. Thank you, Mr. Chairman. I've rambled enough, and I will yield back.
Chair, thanks, gentlemen. Now I recognize the gentleman from Texas, Mr. Green, 5 minutes for questions.
Thank you, Mr. Chairman. And Dr. Stern, I think we're all in agreement that our country has a long way to go to improve mental health systems. I'm also from Texas, but in an earlier life, I actually did probate work, and one of my judges, who was a friend, appointed me to do mental health work, do the probable cause hearings and the commitment hearings. And it opened my eyes to the Texas Mental Health Code, and actually as a state senator, we were able to change some of it. I appreciate Dr. Murphy's leadership for many years on this issue. I have some concern about part of the legislation, though, the Medicaid IMD exemption. My concern is just cost shifting from the state, if the state does it, to the federal government. But I want to get to the follow-up on my colleague from North Texas. Dr. Stern, the Affordable Care Act included a demonstration in 11 states to test whether undoing the IMD exemption for emergency psychiatric care and letting federal funds pay for the care in IMDs that states would currently provide would improve services to the population. It is my understanding we don't yet have enough information to know whether this demonstration has been successful. My question is, it seems to me that before we move ahead and spend billions to supplant the state funds, we ought to see if this demonstration yields any positive results. Do you know, can you update us on any of those demonstration projects?
I'm not aware that those evaluations have been completed, but our position would be quite consonant with yours. You know, that was when that provision was discussed and be made part of the Affordable Care Act, there was a concern that looking at only one element in a system of care just really wasn't the appropriate way to think about how to build an effective community care system. And so we maintained, and the law was enacted, that this had to be evaluated as part of a system of care initiative. Our recommendation is that there be no changes to the IMD law until the results of that evaluation are complete.
Okay. When the Congressional Budget Office, they haven't completed, officially scored the provision. My understanding is it's quite expensive, tens of billions possibly. If we had tens of $billions to spend on improving mental health system in the United States, how would we direct it, and where should we really be looking to invest that money to see the greatest improvements?
Well, you know, I think that we've heard a lot this morning about the importance of assertive, engagement-oriented outreach. Ms. Thompson talked about how important some of that was for her mom and how it would have been helpful had that continued when her mom came home. The committee heard in testimony from Dr. Arthur Evans, who runs the Philadelphia mental health system, about how critically important that there be funds available for crisis alternative services, for peer engagement and outreach services. We know a lot about what we can and should do, and I would much prefer to see those funds spent on fully developing a continuum of care in communities with assertive outreach and engagement.
Well, I'm familiar, at least in Houston, Harris County, with some of the substantial reforms that have been made in the last 20 years. For example, our Harris County Hospital District. When I would first go see a client or a patient, it was literally dismal. It looked like a holding cell in the hospital. But they have created a diversion now to where you actually have committed to mental health treatment. And it's a partnership between University of Texas, where we have a psychiatric hospital in Houston, but it's doing better, but we have less psychiatric beds in Houston, Harris County than we did in the 1980s.
Right.
So that's our big concern. I am pleased with Dr. Murphy's bill that includes a provision to extend the liability for doctors who volunteer in behavioral health clinics. He and I have had legislation for a number of years. It's passed this committee, and somehow the Senate doesn't do it, that would expand for our FQHCs, and not just behavioral mental health clinics, but our FQHCs, where volunteer physicians could go in and be under Federal Tort Claims Act. And that makes so much sense. While it's a good step forward to increasing the mental health workforce, much needs to be done for the developer professionals, and we need to care and treat. Mr. Chairman, both on our Health Subcommittee and I know on our Oversight Committee, Dr. Murphy's doing, there are a lot of examples of things happening all over the country based on local community success. And I think this panel shows that maybe we should, since we do have the Affordable Care Act and mental health parity issues, then maybe we ought to look at some of those examples from around the country and see what we can do to make sure we get the best bang for our federal dollar to help our states and the local communities, because again, oftentimes it's our hospital districts that are providing some of that care. So I appreciate it, and I yield back my time.
Chair, thanks, gentlemen. Now recognize the gentleman from Pennsylvania, Dr. Murphy, 5 minutes for questions.
Thank you. I want to thank all the panel for being here. I really appreciate your time. A quick question to start off with. I'm just going to ask each one if you've read the bill. Ms. Thompson? It's a yes or no?
Not the whole bill.
All right. Dr. Stern?
Not the entire bill.
Ms. Jensen?
I didn't hear the question.
Have you read the bill we're talking about?
Yes, I read the bill.
Whole thing?
Yes, the whole
Okay,
thing.
thank you. Ms. Danowitz?
And yes, I have read the whole thing.
Thank you. Ms. Jensen, in the bill, did anybody else in your testimony today advise you on things to say?
Of course not.
So I'm not sure where you got this statement from that it would make it harder to get housing and education. If there's a point in that bill where you feel this, will you make sure you let me know, because I want to fix that? Would you let me know?
I don't understand what you're saying, sir.
You had said in your statements that the bill would make it harder to get housing and education. If there's a place in that bill where that occurs, would you let me know, because I want to fix
If you
that.
take Pammy away, we have a hard time getting help with housing, education, and jobs.
Don't agree, but thank you. Dr. Stern, I'm just not clear. Are you a clinician that treats patients?
No, I'm a research psychologist.
Okay, thank you. You said SAMHSA does not support programs that are anti-treatment. Are you familiar with the Alternatives Conference?
I am.
Are you aware that alternatives is short for alternatives to treatment?
It's my interpretation of alternatives. It's not alternatives to treatment. It's alternatives available for people to make choices about how to best engineer their recovery.
Do you think everybody is capable of making that choice?
I think everybody is capable of understanding what's important to them.
Ms. Thompson referred to something called anosognosia. Do you know what that is?
I've heard it described, yeah.
Okay. I'm disappointed you don't know what it is. It's critically important. So I got to go into a little lesson here. If a person has a stroke on the right side of their brain, and the left side of their arm doesn't work, a characteristic of that is if you say to this person, try and move your left arm, and they don't, you say, I think you're having a stroke, you need to get to that hospital. The person may say, it's no big deal, I don't know what that's all about. That's anosognosia. About 40 to 50% of people with severe mental illness, schizophrenia, if shown a videotape of them hallucinating, delusional, they don't know who they are, they think they're the angel Gabriel, Jesus, whatever else, and they say, do you think that's okay? They'll say, sounds okay to me, I don't understand the problem. What Ms. Thompson's referring to for those people who are not capable of making a decision on their own, to have someone else assist them so that they have a right to get better, would you agree that such persons may need some assistance that they're not capable of making on their own?
I think in the way that you specifically have characterized the situation, people would meet the criteria for not being competent.
Okay.
And at
Well,
that
that's
point,
important.
I think they could. Yeah, no.
Good.
Yeah.
We're in agreement there. I want to make that. And all do you think in the Alternatives Conference, which spends about $600,000 a year of taxpayers' money, do you think we should be paying for conferences that have things called Unleash the Beast, Primal Movement Workshop, how to make collages, dancing, interpretive yoga, or how to stop taking your medication? Do you think taxpayers should pay for that?
I think it's very important that we have an open
I'm asking, do you
marketplace
think
of ideas.
taxpayers should pay for those items? When we're so short on funds, do you think we should be paying for that for people who have severe mental illness?
I think that it's very important that we have an open forum to discuss the various
I appreciate that. I didn't
Yeah.
ask you about an open forum, so I'm going to take that as a yes, and you're afraid to say yes. Do you know in SAMHSA's, no, it's true. Come on, I want to have an open discussion here. In SAMHSA's documents that describe their strategic plan, it's about 40,000.
May I?
It's about 40,000 words. How many times does it mention the word schizophrenia?
You know, I've not had an opportunity to count them.
Well, it'd be easy to count because the answer is 0. Do you know how many times it mentions the word bipolar? 0.
Yeah.
So when you say SAMHSA is focused on severe mental illness, my problem is it's not. And when I had the leader of SAMHSA in my office and I said, would you change anything? She said no. So what I see here is I think SAMHSA plays a very important role. I want to see it keep on doing that. But I want to make sure we get back to evidence-based care. And I'm assuming you'd be okay with that.
Absolutely.
That if a program shows that it can work, make it work.
Absolutely.
And let's do that. And what I'm concerned here is that throughout the federal government, we've got money in Department of Defense, Veterans Affairs, Education, HHS, who knows where else.
Right.
And we've got to make sure we got programs that work. And the ones that work, expand them. And if they don't, eliminate them. And if they're redundant, merge them. And that's what I want to have happen with this bill. On the parity issue, real quick, I just want to say that there is parity for people who have private insurance and Affordable Care Act. There is not parity with Medicaid, so if you have more than 16 beds, you're not going to get it, and if you see 2 doctors on the same day, you're not going to get it. The last question here I want to address it to Ms. Donowitz. Dr. Stern called the journal editorial a gross mischaracterization, and that SAMHSA for leading an anti-psychiatry movement. What do you have any comments on that with regard to SAMHSA and providing money or grants to groups that fight treatment or discourage?
Yes.
My help.
Yes, and in fact, I have read many of the state applications for grants from SAMHSA, CMHS, and when you read those, you find very little reference to the most severely ill. Much of it is about, this is how we're going to get people out of state psychiatric hospitals. It's about how we're going to, if we just offer people, what they want, and make sure that we're really nice to them, that they're going to be just fine and it's going to settle their symptoms. But the question is, well, what if what the person wants is a semi-automatic, machine gun to shoot you because they think that you are the devil?
Yeah.
Well, then what do you do?
Yeah,
well, then
wouldn't
you
want
call
that.
the police and you get them into jail, and if there was ever a form of coercion, that is it.
Thank you. I have to yield back. Thank you.
Chair, thanks, gentlemen. Now recognize the gentlelady from California, Ms. Capps, 5 minutes for questions.
Thank you, Mr. Chairman, and I would like to thank all of our panelists for your testimony today. I want to signal you out, Ms. Jensen, because yours was so personal, and I appreciate that you were willing to tell your story. Dr. Schern, mental health is an important issue that members of this committee on both sides of the aisle have a shared interest in addressing. I worked in our community and public schools before coming to Congress as a public health nurse, and so I have had experience with this topic, and I'm really pleased that today it's being discussed. We've heard from the testimony that there are some provisions in this bill that have widespread support and others that are perhaps problematic. I know that other members of the committee have also expressed interest in the topic and introduced legislation on mental health, and I hope that moving forward we can have an open dialogue, the chairman just mentioned that, about all of the proposals and ideas. That being said, Dr. Schern, are there any provisions not included in H.R. 3717 that you feel are important to improving mental health, the mental health system?
Well, as we've said on a number of occasions, I think that understanding that a full continuum of engagement-oriented and assertive outreach services are critically important for effective services for people with severe mental illnesses. Additionally, and I think that Dr. Murphy mentioned this in his remarks, or Mr. Pitts, we're continuing to learn about the importance of early identification for people who are going to develop disorders that have psychotic features. And I think it's critically important that we do a much better job at early identification of people who are going to have those most severe illnesses, and we're developing a reasonable evidence base about the things that are helpful to them, because that can stem disability. Yes. I'm also very excited about the peer movement, the use of persons who themselves are in recovery to help with these engagements and follow along processes, and also with appropriate supervision to provide the kind of extensive or extension of the mental health workforce that's going to be required.
Yes, that's the point I wanted to pick up on, because Dr. Wellner, in his written testimony that I read, he noted the importance of having enough mental health professionals. Maybe that's a whole nother hearing, but particularly that it seems to be a hole in this bill, and one that I think we should be addressing with more specificity, actually, I meant to say. Dr. Shern, one of the key principles both sides of the aisle agree on is that we need to do everything possible to encourage individuals, and you talked about outreach, struggling with mental illness to seek treatment. That is actually part of the stigma, the recognition and the clear sort of lack of understanding that we have about our brain and issues that affect it. Treatment does prove to be very helpful, as we've heard today, and is more successful, I think, than some of the public seems to recognize. And early detection, just as you said, and regular treatment are so essential for preventing those rare and tragic cases where individuals become violent toward themselves or others. And we know people with mental illness are actually more likely to be victims. So that's a piece of this story that needs to be clearly said as well. But the stigma is demands, I think, and we should be desirous of ways to address the stigma. Privacy concerns are also intimately related. That's why I'm concerned about the changes to our health privacy law that this bill proposes. It creates entire new standards for individuals who have what the bill loosely defines as serious mental illness, and that's a loose definition, unfortunately. And I know these are difficult areas to find the right path, but that's something we really need to get to. Dr. Shern, first, can you help us clear up a key point of fact? Does HIPAA always require patients to give their permission before information is shared, or do providers have flexibility if there's a threat or if they believe the patient lacks capacity?
It's my understanding that there is flexibility. And, I was thinking also about the Virginia Tech shooting, and when people looked at FERPA and HIPAA then, it was clear that there was a lot of misunderstanding about the bill, and that in emergency situations that can be violent. So part of the thing I think we need, and I think Ms. Thompson would agree, is just better public education about what those laws actually mean.
I'm glad you put that on the record. What impact will the changes proposed in the bill have on people's willingness? Is that a concern to you, people's willingness to seek treatment for mental health illness?
It is a concern of mine, concern of our organization, given the coercive nature of some of the assisted the outpatient treatment programs.
Thank you. I yield back.
Chair thanks the gentlelady. Now recognize the gentleman from New Jersey, Mr. Lance. 5 minutes for questions.
Good morning, and thank you, Mr. Chairman, and thank you for your leadership on this issue, and thanks to Dr. Murphy as well for his leadership. Earlier this week, a bill on which I had worked with Congresswoman Matsui of this committee, the Excellence in Mental Health Act, was included in a larger piece of legislation, and I'm pleased that the President has signed that into law, and I certainly want to work with all members of this subcommittee and the full committee as we move forward on this challenging issue. Ms. Zanowitz, as I understand it, your sister spent quite a few years in New Jersey facilities, including the now closed Hagedorn Psychiatric Hospital in Hunterdon County. Yes, I grew up in Glen Gardner, where that facility was located. Before it was related to psychiatric concerns, it was related to tubercular concerns. It is clear from your testimony that many mental health facilities in this country are currently unable to meet the needs of their communities. In your judgment, would passage of legislation in this regard help in states across the country, including states like New Jersey?
Absolutely. And the closing of Hagedorn Hospital was a travesty. That is the hospital I mentioned. That was the safe hospital that she was transferred to. She got excellent care there. And it was closed. And she didn't move to Greystone, which, as I mentioned before, is a gem. It's a wonderful hospital. Mm-hmm. But as a result of the closure of Hagedorn, it is virtually impossible to get anyone into a state psychiatric hospital now. Mm-hmm. And in fact, the state has implemented what I'll call a gatekeeping process that prevents people, when psychiatrists said this person needs to be in a state psychiatric hospital because they need more than 2 weeks of treatment, they can be shut down by a nurse who's reviewing the process just because the state is trying to keep the population down.
Before your sister was at Hagedorn, what was the state hospital before that, where she was?
That was Ancora.
Ancora.
In South Jersey.
In southern New Jersey, yes. Mm.
And it was a really a very bucolic setting. It was a very nice hospital. When she first went there, there were less than 500 patients, and the care was very good until, because of the closure of the previous hospital, the population grew to 750, and it was truly bedlam. Mm-hmm. Because the hospital, the staff were not able to handle it, and that was when I was able, because I had the resources, to get her moved to a safer hospital. Mm-hmm. But it wasn't until the Department of Justice came in, at the request of the state, and investigated it. The protection and advocacy was nowhere to be found, and in fact I called them at one point, but that was not on their radar screen. They were more important, more concerned with other issues like legislation for AOT and fighting that.
Mm-hmm. Thank you. Let me say that I was honored as a child to know Garrett Hagedorn, who was a state senator from Bergen County, and I had the privilege of being the minority leader in the state senate before I came here, and I have worked on these issues and hope to be able to continue to work on these issues here in Washington, and thank you for being with us.
Thank you.
Today. Let me say that there are, Mr. Chairman, community mental health facilities in the district I represent, such as the Richard Hall Community Health Center in Bridgewater Township in Somerset County, and I hope that these fine efforts can continue and that we can work in a bipartisan capacity on this very important issue, and we're reminded yet again so tragically of the importance of this issue based upon what happened at Fort Hood yesterday. Mr. Chairman, I yield back the balance of my time.
Does the gentleman yield a quick question?
I certainly do.
I just want to point out there's misunderstandings of the HIPAA law, and Dr. Stern, you've never been involved in a case, and you shouldn't be aware of an opinion on it. This bill does not undo HIPAA laws. It clarifies them, and we want to work on language. I've been talking with Representative Daggett on this too. We want to make it so that all those things that are also in the regulations that go along with the law are clarified. It doesn't change anything, but there are a lot of misunderstandings. You're absolutely right. Clinicians misunderstand this all the time. So we want to make sure we work on clarify that, but it doesn't change the law. Thank you.
Chair thanks the gentleman. Now recognize a gentlelady from Virgin Islands, Dr. Christensen, for 5 minutes for questions.
Thank you, Mr. Chairman. I want to ask some questions to Dr. Stern about the bill and its impact on SAMHSA, because the bill makes some significant changes to the way the federal government's mental health investment is structured within the Department of Health and Human Services, particularly in Substance Abuse and Mental Health Services Administration. I want to make sure that I understand the impact these changes could have, particularly to the Community Mental Health Services Block Grant and programs of regional and national significance. Dr. Stern, starting first with the Mental Health Block Grant, how would H.R. 3717 impact this program?
It's my understanding that the block grant would be moved to the Assistant Secretary's office and would have a different type of oversight than it currently has now, providing less flexibility to states, for example, in terms of how those funds are used.
So do you support provisions in this bill that would condition states' receipt of block grant funding on newly established federal involuntary patient or outpatient treatment standards and specific criteria for assisted outpatient treatment?
No, we wouldn't support that.
Could the gentlelady ask him to clarify what that means? Because I'm not sure it's clear what he's saying.
What do you mean? Well, I asked if he would support the provisions that would condition the receipt of block grants on newly established federal involuntary inpatient or outpatient standards.
Yeah, but
and he said no, he would not.
But I'm not sure he read or understand this section there. It would simply say that states, and I appreciate the
Is
gentleman.
this not on my time?
I'm sorry, ma'am. I was asking to yield. I was just trying to clarify. Thank you.
Okay, I want to finish my questions. If I have time, I'll yield at the end. As I'm sure you're aware, SAMHSA has general authorities to conduct programs of regional and national significance in mental health, substance abuse prevention, and substance abuse treatment. I understand funding through these authorities accounts for approximately 35% of SAMHSA's mental health budget and 25% of substance abuse spending. Title 11 of H.R. 3717 would terminate any program by the end of fiscal year that's not explicitly, and this is from the bill, is not explicitly authorized or required by statute, shall be terminated. So how would this impact SAMHSA's ability to continue initiatives pursuant to PRNS authorities like Minority Fellowship Program and National Suicide Prevention Hotline?
It's my understanding that through the appropriation process, Congress can direct and influence SAMHSA's agenda. So in many ways, those kinds of relationships between the legislative and executive branch are already in place. The programs of regional and national significance are extremely important. Most of the innovative processes, particularly around systems of care issues, and many of the things we're talking about today, have come through that program. So anything that would further constrain that, we would oppose.
And in your testimony, you convey support for an initiative to improve interagency coordination of mental health and substance abuse programs within the department. But you seem to have some reservations about the way the H.R. 3717 approaches coordination of HHS programs for mental health through the establishment of that new secretary position. Could you elaborate on the reservations you might have about that?
Well, our sense is that the Administrator for SAMHSA is a direct report to the Secretary of Health and Human Services. And so, in some sense, interposing another layer of government between SAMHSA and the Secretary doesn't seem to us to be particularly helpful. Additionally, we believe, and I think as was mentioned earlier in testimony today, that it's a lot more than HHS that's involved in mental health care. Housing is involved, justice is involved, labor is involved, et cetera, et cetera. And we would concur with Drs. Richard Frank and Sherry Gleed in their analysis of the mental health system in this country, saying that coordination needs to occur literally at the White House level because it's those interdepartmental issues which are important. Additionally, I think since President Bush's commission and its findings, there has been increasing interdepartmental cooperation without imposing any additional structural changes in the government.
Is there anything else you'd like to add about any other areas where the bill could negatively impact SAMHSA?
Well, I think that over bureaucratizing and over regulating and trying to more narrowly focus the agenda of SAMHSA around a particular set of concerns or issues, which generally I think are well represented already in their portfolio, will not be helpful. Certainly, there, as in any human endeavor or any area of government, there are ways that things can be improved. I think that the organization has been mischaracterized in editorials and in publicity surrounding that, and that anything that can further those kinds of issues will be harmful to the people of this country and their mental health.
Thank you. You're back. My time.
Chair, thanks, gentlelady. Now I recognize the gentleman from Louisiana, Dr. Cassidy. 5 minutes for questions.
I thank the gentleman. Dr. Stern, you already mentioned you didn't read the bill. So is there a specific place in this bill that you can make reference to where you have these concerns about the Secretary of Mental Health and what that person will do to limit care? Is there some specific page or paragraph you can reference? to clarify your conclusions?
I'm sorry, Dr. Murphy, I'm not understanding the question.
Well, you made a statement to the gentlelady that this person who would be the Secretary of Mental Health would over-bureaucratize and complicate some of these issues. Is there a specific place in the bill you can tell me where it says that?
What I was responding
I need a specific. I don't need concepts or philosophy. Because what we're trying to do with this hearing is work to improve the bill. So if you think there's something in there, it's important this committee has accurate information and not impressions. Is there something in the bill that, if you don't, you can get back to me on that. That's okay.
The question I was responding to had to do with conditioning the receipt of block grant funds based upon states having effective assisted outpatient treatment provisions. And it's my understanding, and correct me if I'm wrong, that is in fact a provision of the bill.
It is.
I would oppose that.
That is a provision of the bill. That's not the issue with the Secretary of Mental Health. The Secretary of Mental Health.
No, that wasn't the question, though.
Well, part of it. You said it would over-bureaucratize. Do you what are the person who now heads SAMHSA? Do you know what her degree is in? What her background is?
She's an attorney.
Exactly. Haven't we done enough with treating people with mental illness as legal cases? We have closed our hospitals and filled our prisons. We have closed our treatment centers. We have not given adequate funding to community mental health centers, and we've replaced the hospital bed with a flop house or a blanket over some steam grate. That's wrong. I think it's immoral. It puts us in a third world category.
I agree with you completely. I think
I want, for the record, I want the committee to know.
Though.
Yes. There's a lot to do. A person's background should meet their role. Now, I respect that you're here, but it's important to understand you don't treat patients. You have never been involved in a patient case. You have never been involved in HIPAA discussion. You haven't. You haven't, and that's important. You are here as a citizen. But I want to make it very...
Here's a research psychologist who studies these issues
I understand,
for many,
sir, but you haven't read the bill, okay?
The staff
sir, along these lines, let me clarify for the committee. It's my time. Let me clarify for the committee. The federal government spends $125 billion a year across many agencies. The Department of Defense has spent hundreds of millions of dollars, and a group just said that the money they spend on resilience programs and other things doesn't work. DOD has to go back and say, what did we do wrong? Well, we found out that some of the things they're doing is in clearly good programs with regard to evidence-based programs, and some of it is not, and they need to make sure people are following the program. The VA spends a lot of money in mental health, but unfortunately, a study said that about 20% of the time when someone goes into a VA hospital for mental health services for PTSD, they get appropriate care. The rest of the time, they don't. That's wrong. Judiciary spends a heck of a lot of money, and in many states, on jails. That's wrong. We should be treating these people and not letting them go to that area. And we've had many witnesses before this committee that does that. The purpose of the Secretary of Mental Health, and I think you're demeaning the quality of this. I don't want someone who is dealing with 60 million Americans, that 1 out of 5 or 1 out of 4 people will deal with in life, to be some backbench, low-level person. I want this person to have some power and mojo. I want this person to be a clinician of an MD, PhD, or DO level. I want this person to be one who has the access behind their title, Assistant Secretary of Mental Health, to be able to walk into the offices of Judiciary, Defense, VA, Education, HHS, and say, we want your information. We need to know if your programs work or don't work, or if they're redundant. We've got to make this system work. Sir, for the last 20 years that SAMHSA has been around, it's gotten worse. Now, SAMHSA has done a lot of great things, and I applaud them for that, and we want to keep them going. I'm not interested in getting rid of them. I'm interested in beefing them up. But I'm also interested in saying we need evidence-based programs around this country. There's a lot of misinformation being thrown around today, so I'm frustrated. But I also know, you know what, that's the nature of the mental health community. For the first time since Kennedy was president, for the first time in the last 50 years, we have an opportunity in this Congress to say we need to overhaul this system. There have been some great programs that have come through. I applaud Congressman Kennedy and Senator Wellstone. Some of those things have been marvelous, but it's been piecemeal. And I want us to really approach this in a comprehensive way, but sometimes in the mental health community, we're so used to dealing with the dysfunction in ourselves, we don't understand when we have an opportunity. So here's what I'm recommending. When you're given a comment and you haven't read the bill, say, I haven't read the bill, okay? And with regard to this, what we want, what I want, is from everybody, and all the agencies who are out there spreading rumors about this bill too, to my colleagues and other people, send me ideas for amendments. Let's work on this. But let's not play this game. Thank you. I yield back.
Chair, thanks, gentlemen. And now recognize the gentleman from North Carolina, Mr. Butterfield, 5 minutes for questions.
Thank you very much, Mr. Chairman, and thank the witnesses for their testimony today. I'll try to look around, Mr. Tunko, and see all four of you. That's the advantage of being on the bottom tier, but that's fine, Paul. That's fine. But thank you for holding today's hearing. Certainly, mental health is a very important issue. It's an important issue to all four of you. It's an important issue to us, and certainly to the people that I represent in North Carolina. And so that means that we've got to do all that we can at the federal level to ensure that people who are living with a mental illness receive the treatment and support they deserve. As some of my colleagues certainly know, in my prior life, I was a trial judge in North Carolina, served for 15 long years in 32 counties in my state, and so I've seen firsthand what mental illness can do not only to families, but to communities. And so I thank you for your passion. I have read most of Mr. Murphy's bill, and I think it is a good step, a step in the right direction. Certainly there are many improvements that we can make, and I thank the chairman for offering us an opportunity to offer amendments to the legislation, and there will be several. But there are many different people involved in the continuum of care for mental illness, and it's important that we recognize another category, and that is the role of social workers in the continuum of care, and the important role that they play in mental and behavioral health infrastructure in our country. The importance of the social work profession will continue to increase as the mental and behavioral health challenges impact a growing percentage of the population. Statistic, according to the U.S. Bureau of Labor Statistics, the need for social workers specializing in mental health and substance abuse is expected to grow by 23% from 2012 to 2022. That's 10 years. That rate is much faster than the average for all other occupations. Social work is built on a foundation of integrated care, working directly with patients, but in settings including hospitals and schools and substance abuse prevention and treatment programs and family service settings and long-term care facilities. Social workers have a history of working with and across disciplines, including psychiatrists and social workers, pharmacists, nurses, and others, and will play a central role as we seek to improve health outcomes for people with mental and behavioral issues. I understand that part of the goal of this hearing is to identify and fill gaps that exist in the healthcare workforce in an effort to meet the unique needs of different populations, such as our veterans and people living in urban or rural communities or adults. Let me go to Dr. Shern, if I can, very, very quickly. We know that health professions other than MDs and PhDs have a growing role in meeting the mental health needs in the U.S. Can you talk about your experiences and or best practices working with other professionals in an integrated and team-based approach?
Yeah, well, I think that integrated team-based approach that involves several different disciplines is essentially the state of the art in terms of how services are best delivered, particularly for people who have complex conditions or have, in this case, severe mental illnesses. And I think that there are real opportunities and real challenges that we confront in terms of adequate healthcare workforce in general, and that trying to understand and articulate different roles, particularly roles for paraprofessionals, peers, and others, certainly including social work. All of this, what we're talking about in terms of the integration of care, understanding that people live in communities, interact with complex systems, that's the hallmark of social work's approach to these issues. So I think many disciplines are involved. I think the best treatment involves a multidisciplinary team. And I think that's basically considered state-of-the-art in terms of services for people with severe mental illnesses.
How do you see an integrated team-based approach involving social workers and pharmacists and nurses and others, in addition to psychiatrists, contributing to the success of this legislation and addressing mental health needs?
Well, it's clear from research actually that was done in the 1970s that multidisciplinary teams can both save money in terms of decreasing utilization of the most expensive resources and improve outcomes. And the disciplines that you mentioned in your question would be the disciplines that typically would be involved in those kinds of multidisciplinary teams.
Right. Finally, let me go to you, Ms. Thompson, and thank you very much for your very passionate testimony. On another day, I will share with this committee my personal story. I, too, grew up in a home with a mother who had mental illness. It was paranoia. She was not a harm or a threat to anyone except herself, but it had a significant impact on her family and her work. So thank you for your testimony. Do you think this legislation does enough to recognize and encourage an integrated team-based approach to addressing mental health needs of patients and their families? Yeah.
As I said earlier, I haven't read the entire bill. From my understanding, it addresses the issue I have with what has happened in my experience was that there was no quality of life for my mother. So whatever it takes to create an ability for people to have a better quality of life, whether they know what it is or not, whether they're able to recognize it for themselves or not, that I feel we have an obligation to do that.
Thank you. My time has expired. I'm sorry.
Sorry.
All right.
Chair
Thank you,
thanks the gentleman, and now recognize the gentlelady from North Carolina, Ms. Elmers, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our panel. Each one of you have very important information for us today. And I would also like to congratulate and thank my colleague, Mr. Murphy, for the work that he has done on this issue, especially in relation to the HIPAA situation. As a nurse before coming to Congress, I know that much of the misinformation that's there is parochial, and essentially what happens is it is misinterpreted or overinterpreted, and the clarifications are necessary so that each healthcare professional can understand what can be relayed, because it's a very crucial time. So with that, I do have a question for Ms. Janowitz and for Ms. Thompson. Both of you are doing important work, and your stories are compelling, and on the personal level as well. You know, in North Carolina, you know, the past 10 years, the suicide rate has spiked significantly from about 18% to 22%. I represent Fort Bragg, and this affects our military, as you know, and our soldiers as well. In fact, a statistic that I'm reading here that's provided for me says that actually this year, into 2014, there have been more soldiers who have died by their own hand than those on the battlefield. Now, death in itself is not to be embraced. However, when we look at that statistic, we know the effects are incredible, and that we need to deal with this issue. Obviously, medical beds, you know, patient beds, psychiatric beds are so essential, and we're in more need today than ever. Today, North Carolina has only 8 beds in a state psychiatric hospital per 100,000 people. So I believe we are at the lowest ratio. And, you know, one of our largest hospital systems in my area in North Carolina, Wake Med, is basically struggling with this issue. They treat an average of 314 patients a month whose primary diagnosis is psychosis, and this is up 1/3 over the last 2 years. Any given time, there are 25 to 50 patients with a diagnosis of mental illness of some form that are not in necessarily in a dedicated psychiatric unit, but are having to be placed in other areas of the hospital. And as you can imagine, that's difficult for the patient, the family, and then also the healthcare professionals who are taking care of them. Ms. Janowitz, can you give us some points and guidance on how we can improve this mental health bed situation?
Well, I would love to tell you that we could convince states to increase the number of beds and increase the number of long-term and intermediate care beds that are just disappearing. But that's not going to happen. And that's why assisted outpatient treatment is so important, because it is a way of keeping individuals who are not safe in the community without medication on treatment. And there is empirical evidence to show that it reduces hospitalization, reduces incarceration, which, as I mentioned before, the jails and prisons are the new state psychiatric hospitals. If we don't have those kinds of facilities, we have to have a way of ensuring that people who don't realize that they're ill, that won't take their medication any other way, have a means of getting that support. And it's not just a court order or somebody telling them. Right. It comes with services wrapped
with the
through
actual individual.
And I know people have experienced it, and it does not scare people away, and in fact, it improves their lives. So unless we can get more beds, this is a solution.
This is a good way.
For the population we're talking about, not everyone, but the population we're concerned about.
Thank you. And Ms. Thompson, I just want to thank you for the work that you're doing. In Randolph County, which is one of my counties that I represent, the crisis intervention training for law enforcement is making a significant difference. Basically, this is sponsored by you and NAMI, and it has done incredible work in the ability to have those law enforcement officers in the situation know when they have to react and be able to engage and de-escalate the situation. And it has made a huge difference. However, we need to continue to show that this program is working, and we need a greater coverage and reaching out to some of the other law enforcement. How can we extend this problem? Is there? Do you know of the barriers? And I know I'm running out of time, but can you identify the barriers that we can address that might actually be able to help this situation?
The situation in terms of getting more people informed?
Yes, or getting this program in place for more law enforcement to learn about.
This program is vital. You need to give people the tools on how to deal with people in crisis, because if you don't, that's where the abuse comes from. That's where the abuse in the police departments, that's where all of that comes from, is because you're asking them to deal with something that they have no knowledge about. It's not their skill set, and it's not fair to them, and it's not fair to the individual. But that needs to be funded. I mean, there's no way. We can't do it alone. NAMI is trying desperately. We are a volunteer-based organization. We're a nonprofit organization. We try to reach out to law enforcement as much as we can. We need help. Okay. We need funding.
Thank you so much. And again, thank you to our entire panel. Thank you. I yield back the remainder of my time.
Chair, thanks to the gentlelady, and now recognize the gentleman from Florida, Mr. Bilirakis, 5 minutes for questions.
Thank you so very much, Mr. Chairman. I want to thank the panel for their testimony and for, of course, coming to Washington and sharing with us. I'm in addition to being on the ENC committee, I also serve as vice chairman of the Veterans Affairs Committee, and we've held several hearings over the years on the mental health issues, and of course this is an extremely important issue. As a matter of fact, Time magazine wrote back in 2012 that more U.S. military personnel have died by suicide since the war in Afghanistan began than have died fighting there. When they take their own lives, these deaths diminish us as a whole. It leaves behind spouses, children, parents, and siblings who must deal with the loss and their own grief. So when I look at H.R. 3717, and thank you, Representative Murphy, for filing the bill, of course, Helping Families in Mental Health Crisis Act, I look at it from the viewpoint of our veterans and their families, in addition to the general population. I want to thank the witnesses again for coming here today and talking about these issues, so very important. It's an invisible wound that millions grapple with each day. It carries a stigma, as you said, and we need to help remove this stigma so people aren't afraid to seek help. Mental health issues are just as serious, again, as visible physical wounds, in my opinion. We must responsibly address this problem. Too many Americans and their families are suffering, and they deserve proper care, in my opinion. Your experiences dealing with family members with mental health issues or living with it or treating it helps inform a lot of us in the debate. Again, thank you for being here. I really appreciate it, and I'd like to yield the rest of my time to Representative Murphy.
I thank the gentleman for yielding. A couple of the clarifying points I want to make for members. This bill does not cut 85% of federal funding for the programs. It does not. There are multiple sources for that federal funding. This is one of them. And so it's very important that people are dealing with the facts there, too. Doctor, you referred to a coercive feature of assisted outpatient treatment and would make people seek treatment. Are you aware of the programs Ms. Zanowitz is talking about here with regard to the evidence on when AOT can work to reduce incarceration, et cetera?
Yes, I am.
So what I'm trying to find out here, and I recognize not all states do things the same way. For example, California has one county that does this, the rest don't. And some states do it better than others. I think New York does a pretty good job on that. But in this bill, are you aware of how we define who would qualify for assisted outpatient treatment?
Generally, yes.
Well, we very narrowly define that. They've had to be incarcerated before, had multiple hospitalizations. But the rest we leave up to the states, because I think states should decide a lot of this too. So I want to make sure we're making it clear. There's no coercion involved here, but we're saying states have to have something on the books. But let me ask the panelists this.
Can you clarify that a bit, that no coercion involved in assisted outpatient treatment?
This is, I'm saying, with regard to the states, they can put this together any way they want.
Oh, okay.
But we're
no
saying,
coercion of the states.
Yeah, what we're saying here is that it's an alternative to just waiting until someone is in imminent danger, until someone has a knife to their head or someone else's. We want to provide a mechanism by which people are not just waiting for that someone's about to die standard. That's something established in the 1700s. We need to be doing more. So what I want to ask here is, I'm open to other ideas, and what else can we do to make sure we have this integrated care, this wraparound care? I mean, we know when someone is in an acute crisis that they need a lot of help and long term. What would be a couple of those things? Ms. Thompson, can you think of anything that we should make sure we include here?
Well, I think the HIPAA, how HIPAA is dressed is vital, because, you know, waiting until somebody is at a risk to themselves and others is waiting way too long to help them. We're waiting way too long to step in.
So making sure we have some ways that families can participate more would be helpful.
That's
Dr. Stern, do you have any recommendations of ways we could help provide some of these integrated wraparound services? I mean, we have some in here now under the Excellence in Healthcare. You don't have to answer now, but if you can provide us some ideas,
Sure.
I'd love to hear.
And I think we have a pretty good evidence base with regard to that. And I think that
Good.
where AOT has been shown to be successful is in New York, where there was a $125 million appropriation to enhance services.
And off the record, they saved a heck of a lot of money on jails, didn't they?
Yeah.
We have to convince other states.
Enhancing services, I think, is a very smart idea. You know, we agree on 99% of these issues.
Okay. Ms. Zanowitz, I'll get back to Ms. Zanowitz. Do you have any other suggestions we can do? I know you're in support of AOT, but any other things states should be doing we can help them?
Well, I mentioned earlier I just finished a survey of jails and prisons around the country, and this is where we need more help. And it's something that's being overlooked. I think it's coming to the forefront now, but that's where there are so many people with mental illnesses who are refusing treatment, and what happens to them in those situations. I have talked to jails and learned just how horrible and dangerous and heartbreaking it is. And I think it's something that we have to focus on, and not only just providing treatment in the institutions, but keeping them out of the institutions. And I've talked to police officers trained to deal with people with mental illness. I was in a meeting where they asked, after hearing all the evidence, you know, the recovery-based peer support programs the state provides, a police officer stood up and said, well, when I call the state, I can't get any help for this homeless person who is psychotic and delusional. So I think those are the areas that we need to have more integrated services.
Mr. Chairman, for the record, I just want to point out that it's in support of what Dr. Stern is saying. A report says that ACT works, but a report says we also found evidence in the case manager data that receiving AOT combined with ACT services, assertive community treatment, substantially lowers risk of hospitalization compared to receiving ACT alone. So we'll work with you on that. Thank you.
Gentleman yields back. Chair now notes that the subcommittee members have concluded their questions, and without objection, the chair recognizes the gentleman from New York, who's also on the full committee, Mr. Tonko, 5 minutes for questions.
Mr. Chair. Working? I believe it is, yes. Thank you, Mr. Chair. Preliminarily, I state to our colleague and my friend, Mr. Murphy, that many of us are engaged in regard to this bill. We have read the bill and have sent you specific suggestions and how we believe the bill can be improved. We all agree that there are serious issues that need to be addressed, but there are also serious reservations out there to some provisions in the instant bill. I think your intent is right, and we want to continue to work with you, but it needs to be a collaborative process. I commit to keeping an open dialogue here so as to exchange on behalf of the issues and to recognize the importance The issues here, the people most importantly impacted by mental health disorders and mental illnesses are of high need. So we need to recognize that and move forward with the sense that more than one point of view needs to be exchanged here in order for us to move forward most effectively. I also want to make the record clear that the protection and advocacy organizations are already prohibited by federal law from using any federal funds for lobbying purposes. Any lobbying activities conducted by these organizations, most notable organizations, are done with private dollars. This would be prohibited, restricted as lobbying activities with private funds, which, as I'm sure my colleagues on the other side of the aisle would agree with in the wake of yesterday's Supreme Court ruling, could raise significant free speech concerns. And I think those free speech concerns are essential here for these organizations using private dollars. With that being said, I thank you again, Mr. Chair, for the opportunity. This issue is near and dear to my heart. I served in the New York State Assembly before coming to Congress. One of my proudest achievements in 25 years of service in that body was Timothy's Law. I was prime sponsor of mental health parity in New York. I have the utmost respect for the mental health community and for those who advocate. Their resilience, their determination is stellar, and I recognize that. And I recognize the work done by this Oversight and Investigation Subcommittee to examine issues surrounding mental health. While there are many aspects of this bill that with which I strongly disagree within its current form, I think that the intent is right on, and it's in the right place, and I hope that we can continue to have bipartisan discussions to improve the bill. Those struggling with mental illnesses deserve nothing less. So, Mr. Shern, in your testimony, you speak to the fact that our treatment systems should be welcoming rather than frightening. I couldn't agree more, and I think everyone in this room recognizes that voluntary, community-based treatment is always preferable and leads to better outcomes in the long run. One of the more difficult questions we are weighing as a panel is what circumstances more coercive forms of treatment, whether this is assisted outpatient treatment or inpatient hospitalization, might be necessary. In your opinion, when is it appropriate, if ever, to resort to these more coercive forms of treatment when dealing with an individual with serious mental illness?
Well, I think in this, situations in which a person doesn't have the capacity to make the decisions necessary to preserve their safety, or as a threat to another person, which is the standard sort of commitment laws that exist across the country. At that point in time, we have provisions for involuntarily treating individuals. I personally have, when we implemented our New York City program, our Manhattan program for people who had severe mental illnesses and were living on the streets of New York, I personally witnessed people literally running from our program because of the literally running, jumping onto the Staten Island ferry by slipping under the door right before the ferry took off, rather than be engaged by our program. So I personally have experienced people running from care because of coercive interventions.
And Mr. Shern, does the evidence show that assisted outpatient treatment programs are more effective than similarly resourced assertive community treatment programs?
It's my understanding that those situations in which AOT has been shown to be effective, both in the Duke trials and in the New York State experience, were situations in which there were enhanced services available. Compelling people into a service system that doesn't exist is not going to make a difference.
And when states have adopted more expansive need for treatment standards for civil commitment, have we seen an impact on individuals seeking care voluntarily?
Coercive interventions can chase people from care.
Thank you very much. And with that, I yield back as I see I've exhausted my time.
Chair, thanks, gentlemen. The Chair overlooked one member of the subcommittee, so at this time yields 5 minutes to Mr. Griffith from Virginia.
Thank you very much, Mr. Chairman, and I apologize to both you, Mr. Chairman, and to our panelists. I have been involved in another hearing as well, and so I have been running up and down the stairs trying to make sure I got here. I want to agree with Representative Tonko in saying that putting this law forward by Dr. Murphy is a big step. Somebody has to put it forward. We've been studying it for a little while. He decided to take that leap. and I commend him for that, because that's very, very important. There are things in a bipartisan fashion that we can work on to improve the bill. That being said, and I heard Dr. Murphy say earlier he's looking for those suggestions. That being said, I also want to underscore that HIPAA does have to be addressed. Now, it doesn't mean we want to undo the principles of HIPAA. It doesn't mean we want to, let everybody have access. But we heard so much testimony from so many family members who wanted to help, people who loved the individual with mental health problems, who wanted to be there for them, and in many cases were not able to be there to take care of them because they were blocked. They were blocked from having the necessary knowledge to know whether or not they were a risk to themselves or to others. They were blocked because they didn't know exactly what was going on. So we have to improve that. Where I would like to see improvements in this bill is in figuring out how to define that. Because when you look at Section 301, we have a real opportunity to work on that across the board, all parties coming together, and figure out how we do that. My concerns particularly relate to two groups of individuals. You've got the elderly. It's pretty obvious that with an elderly person, if you have competing children. I used to do divorce work in my small town private practice. I did a lot of criminal work. People will fight over all kinds of things, and particularly when it becomes mom or dad, family members get into a fight. So we have to figure out a system where if you've got a child who hasn't been involved in mom's life for 20 years, that they don't come waltzing in and knock Ms. Thompson out, because all family members get it. We also, I worry about in that same situation, the young man. We've heard so much testimony that young men, particularly in that suspect group, 14 to 18 is a problem, but 14 to I think was 28. Dr. Murphy can correct me on my ages, where there's a lot of onset of first signs of mental illness and they don't get treatment. 14 to 18, parents are still involved. On that 18th birthday, they get knocked out. And whether that's what HIPAA is supposed to do or not, it's the way it's interpreted. And if you're worried about a lawyer suing you for giving away the information, you're not going to do it as a doctor, no matter what different people may think it means. Dr. Murphy's right. We've got to clarify it. But then I also worry if you have too big a door for people to get information, does that estranged father come back in, never having participated in his son's life, and now the son is 22 and he decides he wants to come in and knock mom out. So that's the scenario that I'm looking at. I think we can make improvements. And with that, Mr. Chairman, I yield to Dr. Murphy.
I thank the gentleman. I also thank you for your commitment to help us improve that language. It's important. We've had too many people raise concerns. We have to do it the right way. Dr. Stern, you had mentioned that you're aware, let me ask you, are you aware of any study at all, empirical published study, support your understanding that broader commitment standards drive people away from seeking treatment? Are you aware of any particular study offhand, or can you provide that for us?
I can look into it. I'm not aware of any offhand.
Okay, I appreciate that, because you made this statement. I want it backed up with evidence. I also want to say that what I was reading before, the quote I forgot to reference, is where it said that AOT combined with ACT services substantially lowers risk of hospitalization compared to receiving ACT alone. This is in the study done by Duke University Policy Research Associates and the University of Virginia School of Law on the New York State Assisted Outpatient Treatment Program evaluation. So a lot we can learn from New York. One other thing I want to mention, when I refer to some of the concerns I have, and Ms. Jensen, you brought a very compelling story forward on what happened with that horrible place you were in, and I'm glad you fought hard to shut it down. But also some of these groups also cause some problems too. A case we heard was from Joe Bruce. His son, William, was diagnosed with some psychosis, who was in Maine. These advocates came in. This family was completely cut off from being able to talk to their son, which is a HIPAA issue. Yet these advocates could talk to him, coached him during a hearing on this, and told him to say, when he was asked if he was going to be a harm to himself or someone else, say no. He listened to their coaching. He was dismissed from the hospital. He went home. He took a hatchet and chopped his mother to pieces. This was very moving testimony this committee heard. We don't think a group like this has any business telling someone, get them out of treatment altogether. We want professionals involved who are looking out for the best interest of the patients all the way through. Mr. Chairman, I want to thank you for this hearing today. We've heard some powerful information. I look forward to working with my colleagues on both sides of the aisle on this. The good news is we have elevated this to the level of congressional discussion instead of keeping it in the dark shadows. We have understood that this isn't just an issue of violently mentally ill. This is severely mentally ill. We have to work together. I'm excited about this, and I want to leave with a message of hope for the many people who are struggling with mental illness. We will continue to listen to you. We want to work together. We have got to change this system and help you all. And with that, I yield back.
Chair thanks the gentleman and thanks him for his leadership on this issue. This has been a very important hearing, very compelling testimony, very informative. Thank you very much to the witnesses for coming. Now, we have members who may have follow-up questions who were not able to attend. They're in other hearings. We will send you the written questions. We ask that you please respond promptly. You have something?
Yes, Mr. Chair. We ask that these documents be included in the record.
We have unanimous consent request to include in the record testimony of the National Disability Rights Network, a letter from the American Psychiatric Association, testimony by the National Coalition of Mental Health Recovery, testimony entitled Helping Families in Mental Health Crisis Act, H.R. 3717, by the Citizen Commission on Human Rights, a letter by Consortium for Citizens with Disabilities, and testimony by Judge David Bazelon Center for Mental Health Law. Without objection, so ordered. I remind members that they have 10 business days to submit questions for the record. That means members should submit their questions by the close of business on Thursday, April 17. Thank you again very much for attending. Without objection, the subcommittee is adjourned.